recorded. And then we're ready whenever you are, Amanda.
It's just a few people here. It's not letting me show just, oh, that's because it closed. 1 second, folks. My browser shut down on me. And of course they had everything up. So give me just 1 minute while it reloads.
For sure, no problem.
So if anyone was here last week, we covered gut health and toileting success. If you're not familiar with who I am a physical therapist. I treat pediatrics, and I've also had some postdoctoral coursework in pediatric pelvic health. So if you've heard of pelvic health as an offshoot of what physical therapists can kind of specialize in, I have taken coursework in that field, but also have targeted that information for kids. And so my role here at CPTWC is mainly treating from a physical perspective, pelvic health conditions. So things that are physical in nature. So if there's an issue with toileting that is a result of some physical aspect, that's where I am super specialized. If it's psychosocial, if it's behavioral, if it's sensory, there are different professionals that would be ideal for assisting us with those types of concerns, if that is part of the reason why toileting is an issue. So I work really closely with all of my colleagues here that have experience in and expertise in those different areas. So last week we talked about the physical health of our bowel and how our pelvic floor works. Today we're going to be covering the physical health of our bladder and how our bladder works, but also we're going to review the pelvic floor for anyone who wasn't here last week. So by now you should be able to see our presentation here. I'm going to expand it and we'll get into it. So toileting success, this is kind of part 2 of our 3-part series. And this is building healthy bladder habits and to review our pelvic floor. So first stop is whenever we're considering toileting with kiddos, we need to make sure that their systems are ready. And so last week we talked about the bowel and how to make sure that the bowel is ready and healthy in a way that can help us toilet to the best of our abilities. Today we're going to talk about the bladder and the bladder's readiness for toilet learning. And last week we did also talk about how we here are trying to kind of shift our language a little bit and call it toilet training less and less, and hopefully start calling it toilet learning more and more, because that is that's our end goal, right? Is we want kiddos to learn how to use the toilet independently. We of course can train them to use the toilet, but the end goal, in my opinion, should really be learning how to do that on their own, and not just training them that when I'm in the bathroom, this is what I do. It's something that we feel and we make a decision and we go and we're happy to do it and we're not scared to do it, and all of those things. So when is the bladder ready for toilet learning? So first we have to have sphincteric control. And so everything and all of the courses that I've taken, really mostly when it comes to the anatomy and physiology, they're referring to typically developing children. For children that have other conditions, some of these timelines are going to be pushed back a little bit, especially if our physical development was a little bit delayed for any reason. So sphincteric control here, that usually occurs between the ages of 2 and 4, but it's still developing during that time. And so you'll see that some pediatricians or paperwork or the internet will tell you that kiddos as young as 18 months old can learn how to toilet themselves. And so there is evidence that there is sphincteric control as young as age 18 months or 2 years old, around that time. But a lot of the research also tells us that it tends to go a lot easier if they're a little bit older and more aware and have that interest and that buy-in of like why we might be wanting to do it. And so that control, while it might be available or present between age 2 and 4, it is still developing as other gross motor skills and fine motor skills are still developing too. That nighttime dryness, so that sphincteric control overnight usually is solidified around 4 years old. I see kiddos of lots of different ages that are still struggling with nighttime dryness, and that's a presentation or all in it on its own. We can talk about bedwetting and nocturnal enuresis for a full hour about all of the things that could be going on there, but typically sphincteric control overnight should be occurring around 4 years old. Full continence tends to happen between the ages of 4 to 6, depending on the course that I took. It gave us kind of a different age. Girls tend to achieve that continence earlier than boys. And children between the ages of 3 and 7 are still going to have occasional leaks. Those occasional leaks we are not worried about. And what do I mean by occasional? Like one every like month or 2 months, and it starts getting wider and wider and further apart. That's all what we would consider normal toilet learning. And the child is still kind of learning those sphincters and when we can push it and when we can't. But we also have to think of not only the bladder's readiness, but the child's kind of like cognitive readiness, because I have this image here of how bladder control happens in babies. And you can see down here, it's just a reflex loop. We've got our brain, our spinal cord, and we've got our bladder way down here. And so when your bladder fills, it sends a signal to your spinal cord, and then it's kind of just this short loop here. As the bladder gets really full, it signals itself kind of to just empty. As we get older and older, our nervous system continues to mature. And not only does our bladder ready for this, but our neural pathways are maturing too. And we get this signal that goes not only from our bladder to our spinal cord and back, but it goes from our bladder to our spinal cord all the way up to our brain. And our prefrontal cortex here tells us, makes that decision about what sensation we're feeling here and when to relax to allow the bladder to contract on itself and empty. And so if there is a lot going on here that is taking priority over this internal sensation of bladder fullness, like perhaps I'm in a really busy gym and there's a lot of noise and I'm swinging on a swing and someone is over here listening to music or someone's over here having a really hard time and they're crying. What is taking priority right now? Probably you could argue it's not whether my bladder is full or not. So depending on how our kiddos process all of their input from their environment, visual, auditory, all of the sensory systems, and there are 8 of them at least that Miss Kirsten will be talking about next Wednesday. But being able to make that conscious awareness and decision is a huge part of readiness as well, and that like awareness piece. So we need to think of our kiddos frontal lobe development and their ability to make those decisions and things like that. And how that might be impacting readiness, but also attaining full control too. Signs of bladder readiness, other than just the ones that we mentioned before, like things that you can like cling to, would be that your child tends to be dry through their nap. That gives us a sign that they are having more and more typical, not neurotypical, like maturation of our nervous system. Thank you for hanging with me here. And the child tends to stay dry between at least, I feel like the bottom number here is 1.5 hours, so 90 minutes, up to 2 hours. That's when we're starting to see more mature bladder capacity and bladder readiness for toilet learning. For kiddos that are going still every 45 minutes, maybe it's every 30 minutes, they're kind of hanging out down here where this bladder is not quite ready because we don't have that, not only that capacity, but we kind of just have that like constant emptying. Our bladder's not quite ready yet. Awareness, some signs that they are aware of what's happening, even though they might not be able to vocalize that they're aware, or they might say, no, I'm not peeing, when they are, is they stop what they're doing. They're very intentional. You notice a quick pause, and then they might move on, and then you check their diaper after, oh, you peed. That's what that weird little pause was, when you were so engrossed in whatever activity it was you were doing. The stare, I feel like I see this one in my house a lot. It's like a pause. They pause not only their body, but they kind of, their eyes bug a little bit. This is the closest image I could find. It's not quite like that. He looks a little frightened or concerned, but it's kind of like this, where he's a little bit like, something's happening, and I can feel that it's happening. They might tell their parent that they're wet. They might touch their diaper when they're wet, or when they are actively wetting. Or they might like ask to be changed, or they're upset when their diaper is wet. So then moving on to healthy bladder habits. Those were just like signs that our bladder or our body or our awareness is telling us that the child might be ready. These are healthy and happy bladder habits. So things that we want our kiddos to be able to do, that tells us, or not that tells us, that will keep our bladder functioning in a way that is more mature, but also will lay the groundwork for healthy bladder habits moving into childhood and hopefully adulthood. I can't tell you how many people I talk to about this, that they're like, oh my gosh, I've been doing this wrong my whole life. So we'll talk through these keys of having a healthy bladder, like allowing it to fill appropriately, making sure it has enough space to expand and contract, avoiding irritants that could make it contract preemptively or early, and a bladder that empties easily. And so there's a few different things we'll talk about with these. So the first one is a healthy bladder fills appropriately. And so let's talk about normal filling. And so these images here show an empty bladder, and then we can see that, I don't have pictures of the kidneys here, but your kidneys filter your blood. And then anything that we don't need goes from our massive matrix of vessels in our bladder into our renal pelvis and down into our ureters, and will traverse this tiny little straw, it looks like, and it goes down from our kidneys, and it empties from this trigone area of our bladder into our bladder. And so as time goes on, as our day goes on, our bladders our kidneys are constantly filtering the things that we're eating that end up in our bloodstream, and then it creates urine. And so urine is basically waste product that we need to get out of our body. And so as our bladder fills, as our kidneys filter the things that we eat and drink, we get our first sensation to go to the bathroom, usually at around 40% capacity. So at about 40%, you get that first little tinge, like, I might have to go to the bathroom soon, but usually we can put that off, and we should put that off. The first full desire to go to the bathroom shouldn't occur until your bladder is about 60% full. This image is showing what looks like a little bit more than 60% full. This is probably closer to 75-ish, maybe 80 actually. But for the sake of understanding filling, I feel like this was a pretty good image. So then your first desire to go to the bathroom is around 60%. And that strong desire to go, that like maybe you can't always make it in time kind of situation, is anything greater than 90% capacity, because you're literally running out of space. And so usually we want kiddos between 60 and maybe 80%. That's when we should actually be feeling that urge to go to the bathroom and going to the bathroom. For young children, that should be about every 2 hours. As they get older, I believe that, I think I have the norms in here. Maybe I didn't put it, but I believe that where that changes from 2 to 3 hours to 3 to 4 hours, I believe, is age 8. So after age 8 and up, 3 to 4 hours tends to be that that norm of how long our bladder should be able to fill to that capacity, and then be able to contract on itself. Just as we get bigger, our bladder gets bigger, and our capacity should increase too. So what does this mean for toilet learning? Timed voids start usually when kiddos are starting to learn how to go to the bathroom, not in a pull-up or in their underwear. We tend to time voids. I'm sorry if you guys can hear. There's a kiddo right outside my door having a hard time.
Yeah.
I'm hoping that's not too distracting, but time voids.
Yeah, she's in a meeting right now. She's having
Um,
a patient. That's why we can't see her today.
Hi, Tiffany. I think you're not muted. If you could just mute for us, that would be helpful. No worries. No worries. Timed voids. Usually when kiddos are learning, they start frequent. It's like maybe every 30 minutes, you're taking your child to the bathroom to sit down. When this is the way that we're toilet learning, we're trying to just like catch a success on the potty. We're not necessarily we're not asking our child's bladder to expand to that hopeful 60% capacity if we're taking them every 30 minutes, because as we know, normal bladder capacity for a child who's 2 to 3 years old should be about 90 minutes to 2 hours, maybe even longer. So if we're starting our frequent bathroom breaks to try and promote the excitement around being successful and catching the potty and the catching the urine in the potty, then if we're starting at short intervals, we want to bump that up like as soon as possible, so that we're not teaching our child's bladder to go every 40 minutes or to go every 30 minutes. We want them to be able to make it to that full 90 that hopefully they were already able to do before we started toilet learning, in order to keep that bladder capacity where we need it to be, and where it wants to be. It wants to be able to fill for 2 hours, 3 hours. I have an image here of an overactive bladder. Overactive bladder could mean a lot of different things. And I find that not a lot of our kids truly have an overactive bladder, as much as their bladder capacity isn't as big as it should be, because their bladder is used to contracting at that shorter, the smaller amount of fill, so that maybe their desire feels strong at 40% when it should be strong at 60%. And so their bladder is confused because they're used to emptying at 40% when we should be able to make it to that 60% full. And so this kind of gets into that interoceptive piece a little bit of how strong is that urge. I'll talk to some of my older kids about that. That'll come in with like urinary frequency, where they're going at maybe like 8 times before they even get home from school. They've already voided 8 times. And trying to fish out like, okay, what does this feel like? Is it just a little urge and you're responding to every little urge that you feel to go to the bathroom, or are they strong urges, and how much bladder retraining do we have to be doing? And so this shows a normal bladder filling, and so we should be able to fill up. This is like maybe 90% full. We have a really strong desire to go to the bathroom. Our bladder is going to start telling us, hey, find a bathroom quick. I'm going to start contracting soon. Where this bladder is only maybe 50-60% full, and the bladder's already giving us those signals that it's time to go, it's really urgent, but it's not. It's just that our bladder is confused and we need to probably do a little bit of retraining, unless there's a physiological issue, but we're not going to get into that because I tend not to see that as often as I see the bladders that are just overtrained. A healthy bladder also has space. And so this image is really aggressive. Like colons don't tend to go from this size to like 4 times their width, but it's not uncommon for colons to get quite overstretched, which we did discuss last week, and chronic constipation and how that can impact the function of our bowel. But when we have chronic constipation, and this is just I think a cute little image of like a happy bladder and a sad bladder, because the sad bladder is running out of space to expand because there's a whole bunch of poop here that's blocking it. And so we need space for that bladder to fill to that 40%, 60%, 90%. If there's something in the way of allowing that contractile muscle of our bladder to kind of do this nice stretch while it's filling, hopefully nice and slowly, it's going to feel that urge sooner. It's going to potentially leak when the child is not aware, because maybe that bowel is just right there pressing on it. And so it's causing mixed signals, one from an interoceptive piece of, is it full? Is it not full? I'm not sure. I don't think it's full. I swear I just went. Why do I feel like I have to go again? But the bladder is confused and doesn't have enough space to fully expand as it should. And the bowel here, especially if it's firm, but sometimes kiddos will have an soft, regular bowel movements. The size of it is all that it needs to create an unhappy bladder. And so if it's a chronic history of constipation, but now you're pooping regularly, but your colon is still overstretched, that can still impact our bladder. And it definitely, this child, if this was a real client, would need to be going to the GI doctor and figuring out how we can manage that constipation to a point where we're not having the frequent urine leaks. So this whole has space to expand area here of the bladder is really bowel related. And if you weren't able to hang out with us last week when we talked bowel, reach out, and I think there's hopefully the recording available. You can access that, and always reach out if you have any questions. And if anyone, I didn't say this today, but I did last week, if you have any questions as we go ahead and just unmute yourself and say, oh, I do have a question about that. And we can kind of chat. We've got plenty of time today. Healthy bladder, also a happy and healthy bladder. Also, we want to avoid irritants. And so for those of you not familiar, there are very specific types of things that we eat or drink that irritate our bladder. And so we want to avoid large amounts of those, especially for the kiddos who are already like, they were doing so good and now they're kind of leaking. I'm not sure why. And we've ruled out constipation, which is a really hard thing to rule out, especially on our traditional American toddler picky eater diets that we see around here. But something you could also look at too is, what is my child primarily drinking or eating? And is that maybe impacting their bladder's ability to not be so quick to contract? And so large amounts of fruit juices, even if they're the super healthy organic ones, they're not from concentrate and they're a little bit diluted, and there's anything that has like a citrus nature to it. It doesn't necessarily matter if it's like the good kind that is like healthy and organic and natural. It can still irritate our bladder. If it's like one of the only things that your kid drinks, try diluting the juices with water as much as you can. But there are other foods and things that can irritate our bladder. Chocolate. There's so many different, if you type in bladder irritants, you'll get so many different images with so many different bladder irritants, and everyone has their own way of kind of making it easy to remember. I've taken a few different courses, and this list here is pretty encompassing of all of the bladder irritants that I've learned about. Caffeine is the obvious one. I think if anyone here drinks caffeine, you'll notice it's not only a bladder irritant, and it makes you go to the bathroom more frequently, but it also stimulates your bowel by not only the effect of the caffeine, but also usually if it's like a warm drink, that can also stimulate our gastrocolic reflex, which we talked about last week as well. But caffeine, carbonated beverages, highly processed foods, they just have a lot of preservatives and things like that our bladder doesn't necessarily, that our bladder is filtering out of our blood, like we said, with our kidneys. So it's filtering all the stuff that we don't want to keep inside our body and flush it out through our urine. And so things that are highly processed tend to have icky, I'll say, to a lot of my family, like the icky stuff that we don't want to keep in our body. The more processed it is, like the more irritating that could be for our bladder. High acid and high oxalate containing foods, artificial sweeteners, basically a lot of things that were like not intended to have eaten, things that were man-made or that don't occur naturally. Like if you ate a completely raw diet of fruits and vegetables and organically grass-fed meat, you'd probably have very few bladder irritants, with the exception of those like higher acidic foods like tomatoes, I think are high and are a high bladder irritant, as well as like limes and lemons and things like that. Another thing that's a bladder irritant I always put on here is constipation, because of the proximity of the colon to the bladder. And so that can like physically irritate the bladder. Everything else that we're eating or drinking irritates it from the inside, and the colon can be irritating to it from the outside. And so the last one here was a healthy bladder empties easily. And so I do like to make it a point here to talk about the bladder wall and how it's a muscle and it contracts on its own. When you sit on the toilet and you relax your body and you relax your pelvic floor, or stand next to the toilet or urinal, your body should relax, your bladder should contract without you having to do anything. You just tell your body, okay, I'm in a position where I'm allowing urine to exit my body, and your bladder should contract on its own passively. We should not be pushing to make urine come out. That should be a passive process that happens on its own. Which I've been coaching my 2.5-year-old to let the peepees come all by themselves, because he's so excited and wants to do it. He wants to do it and get it all out and as fast as he can. And we practice our breathing. Show mommy how I think in their school they do they blow up the balloon and then they let it fly away, and they practice their deep breathing at school. So we try to mimic that when he's sitting on the potty. But trying not to have your child like pushing to help get all the peepees out, or especially if they didn't have to go, let's say they went 45 minutes ago and we're about to leave to go to the store. So we're making them sit on the potty and they're like, I don't have to go. And then they're sitting on the potty and we're like, come on, let's just see if there's a little bit left. And they're like trying to push to get some out. We're always going to have a little bit of urine in our bladder. There's something called a post-residual void. And so, yes, post-residual. We have a small amount of urine that remains in the bladder after it fully contracts. And so even if you or I just peed 5 minutes ago, we got up, we went to go do something, and someone said, you need to go sit down and go pee. And we could sit down and a little bit would dribble out. And we would be like, see, I knew you had to go pee. No, you didn't have to go pee yet. You actually, your bladder, as an anatomical function, always just has a little bit left over after we void. So for the child who maybe did have a nice full void 45 minutes ago, and we're needing to leave to make a 10-minute drive to the park, making them go in that moment, they probably are emptying. They might have to push to try to get a little bit out because they're wanting to get it over with. But we don't want to encourage pushing to get the pee out. We also don't want to encourage just in case peeing, because it doesn't allow our bladder to fully fill, but also it confuses our detrusor muscle, and in that we're not allowing that to fill to that 60% capacity. So that detrusor muscle relies on the expansion and contraction of the bladder wall to be able to know, am I at the 40%, am I at 60%, or am I at 90%? And so if we're constantly telling it to contract when it's not time, we're just in case peeing, we're confusing that bladder wall and its ability to tell us when it's a full void or not quite a full void, that we're ready to sit on the potty. So that's one aspect of the bladder, or the bladder emptying easily, is the bladder wall itself and that contractility of it. But we also have our pelvic floor muscles here. And so let's say we're sitting on the potty and our detrusor muscle is ready. It is ready to relax so that we can let all of the pee out, but our pelvic floor is zipped up real tight and it's squeezing. Your bladder is going to be real upset because now it's starting to contract, but there's nowhere for the urine to go down. It can start exiting up our ureters. It's called vesico-uterine reflux. It can go up our ureters and back into our kidneys. It's a whole big mess. So if we do have like a hypertonic pelvic floor, maybe we have a neurological condition that gives us increased muscle tone or spasticity in our bladder or our pelvic floor, that can impact the bladder's ability to empty easily out of our body and not up and into our kidneys. But for our withholders that like withhold urine, they're squeezing their pelvic floor. They're not allowing their bladder to empty easily. And then we'll get into the pelvic floor and how to help them relax when we review our pelvic floor. But when we urinate, we actually relax our body and our pelvic floor a little bit more. On EMG, they found that relaxing your pelvic floor, you need to relax even more for urination than bowel by, I think it was like 12% or something. It's a small percentage, but we have even more relaxation when we're peeing. So for our new learners, that might mean that boys and girls alike, we should be getting into a position that helps them relax more. Like using a little potty, or having like the steps, double, triple step stool near the big potty so that they can get their legs fully relaxed to go to the bathroom. I have this little image down here. Floating over the top of a toilet does not allow your pelvic floor to fully relax, as well as if you're fully seated or in a position of almost like a squat, which we'll review today too. And I have a quick little video we can watch too. And so something that I talk about a lot with my families as well is what does it sound like, and what does the flow sound like? So when we pee, it should take anywhere between like 8 to 10 seconds for most of our kids if their bladder was properly full. It should start off a little bit slow. It should kind of increase in speed, and then it should kind of like slowly taper off. And that like slow slope, like bell curve here is what's considered normal. For kiddos who void and their pelvic floor is part of them not being able to fully relax, you'll see it on, off, on, off, on, off, on, off. And so these yellow lines here are like, I'm thinking that's when the child was probably contracting their pelvic floor. Urine flow actually completely stopped here. It was on, and then it was off, and then it was on, and it was off. And it's like, what is, for me, this is just like knowing that the pelvic floor is on or off. But for me, I'm also like, what is the child doing? Are they fidgeting around on the toilet? Are they kicking their legs back and forth so to relax? This is a very clear what is going on here. This child is trying to relax. I did a really good job. Their muscles were relaxed. They for some reason went to go and squeeze. It came down really low, and then they were able to kind of relax again here. The plateau like this usually means there's something going on with their bladder, where it's like long and slow, and it doesn't really have like this like very clear peak and stream there. So the bladder should empty easily. We should be able to almost like hear it, and it should be like slow increase, it gets louder, it gets faster, and then it should kind of slowly taper off. That would be considered normal. So then let's review the pelvic floor here. Any questions before we move into pelvic floor about normal bladder, normal function, before moving on to the pelvic floor review? So same slide from last week. The pelvic floor is a group of voluntary muscles. They help us maintain continence. They are at the base of our core. It's the, we have our core muscles on the front. We've got our oblique muscles on the side. We've got our spinal muscles along our back. We've got our diaphragm here and our pelvic floor at the bottom. And together, all of those muscles make up our core, our true core that keeps us strong and stable and gives us postural control and balance control. And our pelvic floor obviously has a role in sexual function as well, but for our purposes, we won't need to get into that. This is my favorite visual. If you were here last week, we talked about it. Our pelvic floor should be resting on the first floor when we're just kind of sitting around doing our thing. We're running, we're jumping. Our pelvic floor should be increasing up to this like fourth floor to prevent any sort of leakage while we're running and jumping. Sneezing, coughing, we trip on our foot on something, our pelvic floor should turn on. We shouldn't be leaking. When we are done doing those kind of higher stress type activities, it should return back to our first floor. When we're going to the bathroom, our pelvic floor does not need to be on. We don't contract our muscles to help pee or poop get out. We actually relax them. We fully relax our body and our pelvic floor to open our urethras and open our external sphincters. Our anus and our urethral opening should be nice and wide and relaxed because our pelvic floor has turned off. It should move from our first floor down into our basement to allow everything to leave our body. And then when that is done, it should return back up to the first floor. This is where our ability to sit still and breathe and access our calm parasympathetic nervous system, our rest digest type of state, which is hard. Our kiddos that kind of live in fight or flight are probably a little bit up here, maybe on the second, third, or fourth floor. And so getting them to stop their body, calm their body, and relax their body to come down into the basement here can be tricky. For other kiddos who maybe are like very weak or not super strong, they might be sitting on the potty without proper supports. Maybe they don't have, maybe they're on the adult potty with a potty insert, but there's no handles or there's no back support, or their feet are dangling. They might not be able to fully relax their pelvic floor because, as we just mentioned, our pelvic floor is at the base of our core. And so if we're needing to use our core and all of our postural support, and we're trying to balance up there without falling off, we are going to be turning our pelvic floor muscles on. So it is going to be hard to allow our pelvic floor muscles to fully relax and to get all the pee out and all the poop out of the potty. So we need to, for our kiddos who are super weak, or maybe not the strongest, or maybe have lower muscle tone, we want to make sure that they are fully supported from the floor up. Their feet are supported, their little tush is supported, maybe their back is supported if they're really lower muscle tone in their trunk, whether that's resting their arms on their knees or having something where they have like lateral support at their thighs, so they can really try and relax to allow that pelvic floor to drop. So things that look like pelvic floor contraction, things that you would see in a kiddo who's doing a good job trying to keep poop or pee in, that would result in contraction of their pelvic floor. They might be sitting on their potty and doing a little potty dance. They're not fully relaxing. Maybe they're running around. Their pelvic floor muscles are on. It's contracted. We access our parasympathetic or our sympathetic nervous system. We can do this to keep our pelvic floor muscles on, to keep our bladder and our bowel like totally. I don't need to worry about that because I am on like high alert, running, jumping, tiptoeing, shallow breathing, that like chest wall breathing, that all accesses our sympathetic nervous system. Kids will forcefully squeeze their knees together. They'll sit with their heels like right up by their anus to help like cue them to squeeze their pelvic floor and to close that up. They'll put their hands on or near their bottom. I've had kiddos put their fingers like right where the poop comes out, just to try and like hold it closed from like the outside. They'll squeeze their bottom, they'll squeeze their abdominals, they'll lean back on the potty. If they're at all sensory or emotionally dysregulated, those are all instances where our pelvic floor tends to be like wound up. So when we're in the bathroom, it would make sense that if we're doing any of these things, our pelvic floor muscles are going to be on. It's going to be really hard to relax our body in order to fully void. And so if you have a kiddo or you've had that experience where, wow, this is stressful for you, this is stressful for me, what on earth are we doing in here? But it's not relaxing and it's not going to the bathroom. We need to pump the brakes. We need to take a step back. We need to figure out how can we help that child feel confident and calm and at peace to relax their body, to allow their pelvic floor to even think about going into the basement. Some things that we can kind of like hack our bodies a little bit, and ways to access that relaxation. First and foremost, we need to be in a calm, regulated state before even trying any of this. So pop back next week for a sensory system and how that might impact toileting. But we need to be able to like be in a state to like ready to learn. In order to access our parasympathetic nervous system, we want to do slow breathing, relax our shoulders down, especially if you know the difference between a chest breath and a belly breath, and allowing your belly to kind of rise and fall. You can feel the difference when you take a big breath in and you allow your shoulders and these muscles in your neck to like pull off and like really help you take a breath in. That breath feels different than when you relax your shoulders down your spine and you maybe put your hand on your chest and your hand on your tummy and you try to just let your belly rise and fall. You can feel the difference that those just two different types of breaths can do on how your body feels. We can also try and help kiddos be positioned for ideal muscular relaxation of their pelvic floor. We touched on this really briefly last week, but I do want to dive into it a little bit more this week. We're going to use this unicorn visual, and these images are going to be helpful after. So as long as you can still see this is a Squatty Potty commercial. It is showing a unicorn going to the bathroom. And this guy is totally ridiculous. if you want to watch the full video, it's very easy to find. For some reason, this is not. I want it to be bigger. I swear I'm not. Why is this zoomed in so weird? I'm just gonna leave it like this. So this is showing the unicorn sitting on the potty with its hooves on the grass. And you can see here, this is demonstrating our rectum. It's the same concept of squeezing and relaxing and how it can help us relax our pelvic floor for both urine and stool, but the rectum is really obvious. So when you're not in a deep squat position, your rectum is kind of kinked. So there's a little bit of a kink in the hose, the gentleman will describe here, and this is dramatic. It's allowing the ice cream to kind of really fill up here. And so in a second here, it's going to show the unicorn going from a sit to a squat, and how the angle of the rectum is now much straighter. It's not totally straight, but it's straighter, and it's a lot easier to allow stool to pass. And the reason it's straighter is because our pelvic floor has relaxed. And so that way we're hopefully getting a full evacuation of our bowels, and that unicorn is doing just such a stellar job going to the bathroom. And so this is my favorite part here, because it shows the unicorn starting with their feet down. And then as the hooves, so you can see the kink in the hose, and then as the hooves go up, the kink in the hose kind of goes away. That pelvic floor was relaxed to allow that to happen, but the position also helps. So both positioning and relaxing our pelvic floor are important for that. So here you can see bad position, kink in the hose, potentially harder time getting that stool out. Now, full squat, relaxation of your pelvic floor. There's way less of a kink in the hose, and that stool is able to relax. And so this last video here, I wanted to show you guys. I think it's just a good visual to be able to see that pelvic floor. So if you're looking at your body, right? You've got our pelvis here, we've got our large intestine here. We're going to pull all of those organs out. And at the base of all of that is our pelvic floor. And so if we go up to about 1 minute here, now we're going to look from the back. This is our tailbone, anus. This is the vaginal opening and the urethral opening. This is the female pelvis. And it's going to show contraction and relaxation here at the 1 minute mark. So that's squeezing to close everything, keep everything inside my body, right? Relaxing to allow everything to come out. Squeeze to contract, keep everything in, relax, open, let everything out. I think I'm very visual, so I feel like visual is helpful. And so, yeah, we were not going to cover urine system assessment unless someone had a very specific question about it. I had a quick slide should we need it, but we're running out of time very quickly. So I wanted to save at least a couple minutes for any questions about bladder and the things that we talked about, or the pelvic floor specifically. If anyone has anything that's really like jumping out to them that they want to talk about.
I had a question.
Hi.
Hi. We've been working with our daughter for potty training for several years. She's 5. She has Down syndrome. And one thing we noticed when we were tracking every void for about 3 months is
Wow.
that
That's
she had
commitment.
where, yeah, well, she's nonverbal too. And we know there's a little muscle tone issue, but she will stay dry overnight, or she'll wait till she
Incredible.
wakes up to like fill her diaper. And she does go regular, like 2-3 hours without needing to pee.
Amazing.
But we noticed, and we started putting her on the toilet and doing it as regularly as possible. She would hold it, and then as soon as that pull up was on, she would go. Or when we say, okay, it's time to use the potty, or 2 minutes we're using the potty because we got to warn her for transition and whatever, she would go in her pull up right before she sits on the potty. And when she was younger and we were doing this, we had pretty good success. We would catch it quite frequently. And she
Mhm.
was getting all the praise, even though she didn't understand what was happening. But then, like, we had a gap when she was going to Chicago Public Schools and they didn't do anything to help her toilet train.
Oh,
And things at home got more difficult. So, like, anyways, we know she can hold it. We know she has bladder control,
yeah,
right?
it sounds
Are
like
those
it.
are signs of bladder control, right?
Yeah. Yeah, no, it sounds like if she can be like dry overnight, she can make it those 2 hours, sometimes 3. It sounds like bladder capacity is there. It sounds like neurological readiness sounds like she's there. Um, sounds like she can hold it too. And it sounds like she has control and she can make that decision of when to empty it. So it sounds like physically bladder, pelvic floor, that all sounds actually great. It sounds
Yeah.
like maybe this, like, I'm keeping it in my pull-up as like, maybe that's a security thing. Maybe that's, maybe the, whether that was the weird transition with schools not supporting her in the way that you guys were supporting her at home, maybe created, whether it was fear or avoidance or fed
Yeah.
up.
Yeah.
Um,
It's hard to tell because she can't talk to us about it.
yeah,
And we
that's
can't,
weird.
we ask her, like, do you feel potty? Do you feel pee pee? Can you feel the pee pee in your tummy? And she just gets upset and doesn't want to, like,
Yeah,
talk about it.
she might be feeling like she's over the conversation.
Yeah.
I did, I've noticed Jim and Sarah, you're both here. I did reach out to her team. And so we've kind of got an email going back and forth about some strategies that we can consider. My thought for someone like your daughter would maybe be something like almost like a social story
Mhm.
that is like specific to her, and like using pictures of her and her environment to
Mhm.
try and help her like take a little bit of ownership over it.
Mhm.
I've got some ideas. So
Yeah, I know it's a bigger conversation, but, like,
for
with her low
sure,
muscle tone, the bladder control's always been kind of like, I think she has it. I'm not sure if she has it. And also,
it
like, can
sounds
she really
like at a
feel the
certain point
sensation?
along your journey, she for sure sounds
Yeah.
ready
Yeah. Okay. Well, thank
physically.
you. Yeah, I know.
There's a lot of components, but yeah, let's keep talking for sure.
Thank you.
Um, we'll get something on the books for sure.
Thank you.
Anybody else before we gotta run here? Okay, all right. If you guys